our basic management strategies have changed a little after Dues 2 came out in 2017, and we learned a lot from them. Earlier also we had a structured way of doing it, but it became a little more structured as Srini has made the job easy by alluding to this. So basic aim of the management is to achieve homeostasis of the tear film and alleviate ocular discomfort. Obviously, the patient is not interested in homeostasis. He doesn't understand the meaning of the word. He wants his ocular discomfort alleviated. For this, we need to know the cause first. And then we have a 4-stage management algorithm. After Srini's explanation to you about the necessary investigations and classification into evaporative and aqueous deficient, or predominantly evaporative or predominantly aqueous deficient, we then come to a 4-stage management algorithm, which gives a stepwise approach for approaching these patients. So there is a step 1, step 2, step 3, and step 4 approach that we do. As I said, after you've classified the patients, what are the treatment options that we have? We need to look at, besides looking at the eye, maybe we need to pay some attention to dietary modifications. These patients sometimes need to drink more water. To produce water, you do need to have a sufficiently hydrated body, and your cells need sufficient hydration. Ashok has alluded to anti-inflammatory therapy, which plays a big role, especially in your aqueous deficient dry eye patients. And of course, you need to use lubricants as treatment for tear insufficiencies. You need to replenish those tears. Everything that you do is not effective if your lid is not blinking well. So if there is entropion, ectropion, or an issue with the improper closure of the lids, you need to address this so that the tears, as Srini said, not only disperse like the windshield wiper across the eye, but also there is a tear clearance to allow good, healthy new tears to come in. And sometimes you need surgical approaches. So it's a multidisciplinary sort of approach to the management of dry eye. But let's talk about the main thing, which is for the general ophthalmologist, is the treatment of the tear insufficiency. So there are 3 ways of tackling this. One is tear replacement. So what is lost, you replace. If the by artificial tears, lubricants, it could be aqueous supplements. Hopefully in our country, supplements in a short while. And sometimes it could be biological supplements when nothing else works, like autologous serum, maybe 20%, 25%, which you can get your eye bank to make for you, or your blood bank to make for you. Our eye bank makes it for us. Then you need to conserve the tears which are already there. You're assuming that the tears are good quality. So typically I would do a tear conservation in an aqueous deficient dry eye when the patients have been on cyclosporin for at least 2 to 3 months. Then I check with dissolving punctum plugs, which are collagen plugs. And if the patient feels a wow factor in a day or 2 after you put those collagen plugs, then you know that his tears are of good quality, and the permanent plugs will help. Dr. Kazu Subota, who himself suffers from dry eye in Japan, introduced me to moisture chamber spectacles, where he uses those tight-fitting glasses which can retain the moisture in the eye. Little uncomfortable, they look a little funny to wear, but they do work. And of course, now we've got new things in tear stimulation. We always had oral pilocarpine as a tear stimulant, tear producer. You have topical secretagogues. And now you have nasal neurostimulation by 2 methods. One is something being pushed into the nose to stimulate the nose. And finally, it not only improves reflex tearing, but also basal tearing. And then there are external gadgets that sit outside the nose, which also stimulate the nose. So this is something new we learned after Dues 2. So artificial tears remain the mainstay of treatment, and there are all sorts of artificial tears come in the market. The good news for all manufacturers of teardrops is that Dues 2 very categorically said that there is no real superiority of one over the other, and very few randomized clinical trials have actually compared and come out, because it's such a vast differences between patient to patient. So these are some of the teardrops that we have: CMC, HA, and combinations of these, and HP Goar and combinations with it, and HPMC is still there. You have osmoprotectants, tiny molecules that go into the cells and hold on to the water in the cells, like L-carnitine, betaine, trehalose to some extent. As I said, lipid supplements are not yet available. Hopefully we'll get them. And then all the drops contain some preservatives some friendly, some less friendly, some inactives which are used to stabilize the teardrops. So osmotic, we won't go into all the various ones, but you can use hypotonic tears were used and came in a big way, but they're really not very useful and have gone out of the window now. And of course, topical cyclosporin is what Ashok has spoken of. Anti-inflammatory can be either steroids or cyclosporin. To some extent, tetracyclines, especially when there's a lot of myobomitis involved in these. And there are some other newer products, biologics, which are showing a lot of promise. Dietary modifications, as I told you about, whole body hydration, restriction of alcohol intake that dries your eyes up. Many people don't realize this. Omega-3 and omega-6 fatty acid supplementation. There was the DREAM study, but there are limits which said that omega-3 is not as good as a placebo. But there are limitations to the DREAM study. It was with fish oil, and in our country, it's made with different other sources. So I still use omega-3 from time to time. So basically, there is a staged method. Your step 1 is inadequate. You can go to step 2, then step 3, and step 4. So step 1 is education of these people and eliminating the offending thing. If there's an air-conditioned blast coming on them, you can avoid that, and proper lid hygiene. And any teardrops is fine. In step 2, if it doesn't work, then you go for non-preserved tears. This is where you would use punctum occlusion. If you have access to LipiFlow, in the case of myobomitis, you would use this once maybe in 6 months or so. And the topical anti-inflammatory cyclosporin and lifitic dust, when it's available in our country, can be used as well. In step 3, you might have to go for oral secretagogues, some autologous serum in a non-healing ulcers, and maybe some scleral contact lenses as bandage contact lenses with fluid in them. And in step 4, really, you're looking at surgical options like salivary gland transplants, tarsorrhaphies, parotid duct transplants, and in end-stage keratoprosthesis to improve vision. So the summary of management, it's important to find out the cause. A 4-step approach is what is recommended by DEWS 2. Here, conservation, supplementation, and stimulation. In fact, the stimulation part will come in a big way in the next couple of years, I feel. Thank you so much. And I apologize if I've carried coals to Newcastle and told you what you already know. I look forward to others lighting up the discussion with fresh ideas.